Just going to spend a few minutes talking about the role of pathology and the pathologist in pancreas cancer. And as I thought about this topic, I wanted to ask myself the question, what do patients need from the pathology examination in 2018 and going forward? So by way of outline, I'm going to touch on the approach to the gross specimen, including issues of frozen section, et cetera. What's new in staging criteria for the AJCC with the 8th edition, which is just now in force. Some challenges in biomarker analysis and the need for an institution-wide approach to tissue banking. So I think I have to use this. So, from a surgeon's point of view and a clinician's point of view, the approach to dealing with tumors depends to some degree on where they are in the pancreas if one's going to do surgery. So head of pancreas is defined as things to the right in the patient of the superior mesenteric vein and portal vein confluence, body between that and the end of the aorta, and then the tail. So in getting a Whipple specimen, which is where a lot of questions come up for frozen section, this is a sort of pristine example. This is the distal duodenal margin. The duodenal sweeps over here, and the head of pancreas is nestled in this area with some overlying fat. This is the common bile duct orifice, and a slice of that is sent to us for frozen section by Dr. Cha and Salem for us to hopefully clear that margin, and then off they go to continue the surgery. In terms of the pancreatic margin, the neck margin in a Whipple, this is the posteromedian aspect of a Whipple resection, and this area here is the pancreatic neck margin. That is the pancreatic duct there. And the uncinate area here, this smooth area here is the vascular groove, which is also sometimes of interest at surgery if we've been hearing about the resectability or vessels abutting that margin. So we pay close attention to that. Believe it or not, we sometimes have to struggle to distinguish the primary site in a Whipple resection, distinguishing pancreatic from cholangiocarcinoma within the pancreas from ampullary tumors. And this can be challenging because large tumors can overlap as they grow. Origin actually matters because for several reasons. One is the prognosis is different from ampullary to cholangio and to the worst one, which is pancreas. Adjuvant chemotherapy options differ, and for example, the use of neoadjuvant therapy is largely reserved for pancreatic adenocarcinoma. So I'd like to just illustrate some classic examples that are pretty easy to decide on some gross specimens. The gross is a pathology term. It's not meant to be an adjective. This is the duodenum is opened up here, and this is, I'm sorry, it's really hard for me to see here. The ampullary area would be right in here. We paint the common bile duct green and the pancreatic duct yellow so that when we see them under the microscope, we're really clear on which we're looking at. So in this portion of pancreas, there's this nodularity. This is all cancer. And notice there's a thin separation between this and the common bile duct. So this is pancreatic adenocarcinoma, and I feel very confident that that we can distinguish that from intrapancreatic cholangiocarcinoma. Getting to microscopy, this is just a needle biopsy of normal pancreas showing the acinar parenchyma, these packed glands of acini. They secrete the enzymes into ductular structures, and then these coalesce to form the main pancreatic duct. These are islets of Langerhans. So this is all, blown to bits in an invasive adenocarcinoma of the pancreas, where the parenchyma is completely replaced by two things: cancerous glands in various density, size, and shape, and a abnormal stromal response, which consists of fibrous connective tissue and inflammation. So on high power, you can see these are some cancerous glands. The nuclei are somewhat enlarged. There's some mucin in the cytoplasm, and the purple dots here are lymphocytes. So that is pancreas cancer, gross and microscopic. So in this example, this is a slice right through the head of the pancreas. This is the radial aspect of the resection, and this painted green is the common bile duct, hugely dilated because it was obstructed. So this is a classic cholangiocarcinoma arising in the intrapancreatic portion of the common bile duct. And so you can believe me, you can see, yeah, there's a nodular mass here, and so that is straightforward. Under the microscope, cholangiocarcinoma looks field for field like pancreatic adenocarcinoma. There really are no distinguishing features and very little on any special stains or anything we could do to tell the difference. So that's why we have to put a lot on a very careful gross examination. Likewise, ampullary carcinomas, they are a little bit easier, except that sometimes as they grow, and now this is a fixed specimen in formalin, and the pancreas is going away from you into the wall. Here's the common bile duct, the pancreatic duct, and this sort of rolled edges is an adenocarcinoma that actually began in the ampulla, this almost invisible space, and rolled out onto the duodenum and a little ways into the pancreas. So we have to, have our wits about us and do a little bit of work to sort that out. So in addition to this, I want to point out that there have been some changes for the clinicians in the room. They know this. In the definitions of the American Joint Cancer Committee TNM classification scheme for pancreas, then this edition just came out. It's become active only this month, last month in January. And so folks may not be completely aware of it. But the main changes are the T and N stages. So T3 used to be denoted by tumor, didn't matter the size, but that it got into the peripancreatic fat. I'm going to tell you why that's really not useful. Now it's a size difference, so less than 2 is T1, and then they've even split that off into ABC. 2 to 4 is T2, and greater than 4 is T3. The end stage has also used to be just yes, no, N0 and N1. Now it's sub-staged into N1, 1 to 3 lymph nodes, and N2, 4 or more. And that's because in several studies, there's been found to be sort of a meaningful prognostic difference in survival in 3 or less nodes and 4 or more nodes. In terms of the T stage, there's some elegant studies done by multiple groups, including Hopkins and Memorial, where they documented 2 things. This T3, this old T3 is no good. First of all, it's actually present, if you look carefully, in 91% of Whipple specimens. So how could that possibly be a distinguishing feature of meaning? And second, if you go by size instead, this new 4 centimeter, they did find some meaningful survival differences that seem to make sense, depending on the less than 2 to 4 and 4. So this is the new world. The last gross photograph is to deal with the issue of how to handle the pancreatectomy specimen in the setting of neoadjuvant chemotherapy. So these specimens are challenging on gross exam because, and here we have the duodenum again, and then this is the common bile duct, and the pancreatic duct is over here. We really can't pinpoint it. Great for the patient. If they responded, you really can't see anymore a definitive pancreatic mass. And yet we're looking for microscopic disease so we can properly stage the patient following neoadjuvant therapy. And this is important for their prognosis. So in fact, we have to embed the entire pancreas if there's no mass seen in order to ensure an accurate assessment of residual tumor and lymph node status. A couple of studies show this is meaningful. One from Hopkins, that a complete pathologic response, meaning there was no tumor found, was associated with an increased disease-free and overall survival compared to near complete and limited response. And apropos to the discussions we heard at lunch and earlier today, the inflammatory response now, this is all the rage, and after neoadjuvant therapy, or perhaps even before, should this be characterized and quantified in some way by pathologists? In the resections. And so, for example, in this study from MD Anderson, it was found that after neoadjuvant therapy, patients who had a high CD4, so these are T cell markers, and a high CD8 to FOXP3 ratio, that implies that the CD8 cells are unlocked and ready to go, they're not regulated, those high values were associated, again, with increased overall and disease-free survival. So I actually propose this as a question, is this something we should think about doing? In the neoadjuvant setting, the tumors look very different if they've responded. There's a tiny bit of tumor here. Mostly there's fibrosis, islet cell hyperplasia, and inflammation, lymphocytes in these settings. So I'd like to move on to talk about challenges in biomarker analysis. And there are basically 2 main challenges. First, as you can imagine, tissue is the issue of triage of tissue for molecular signatures. So patients sometimes need specific tests in order to be eligible for clinical trials. or to decide if they're not in a trial, which chemotherapy option might be available to them. And then we might want tissue to do some of the research that you heard about at lunch today. And as James reminds me, in 70% or so of patients, the biopsy represents the only tissue available for study, either of the primary or the metastatic site, because these patients are not operable. So you can imagine there are competing demands for very small amounts of tissue. Sometimes we want to do things today. We want to do tumor profiling. Maybe in 3 months we've decided we wanted PD-L1 to do off-label therapy with a checkpoint inhibitor. MMR status is now requested in many solid tumors for the same reason. And then there are specific clinical trials, such as one that is ongoing at Yale, started at Yale, for an antibody to mesothelin. I'm going to talk about that in a second, illustrate it. And then aside from clinical matters, we might want some of this tissue for research. The other sort of sticky wicket here that I like to raise is that there's a potential for different results in any of these analyses, or some of these analyses, in the primary tumors compared to the metastatic foci. And that's something that I think pathologists, we don't have a handle on, how to deal with that, are we to test both when we have them? Should we insist on testing both? If we've only tested the primary and now the patient has liver met, et cetera. So I'll talk about that in a second as well. Just by way of information, in 2016 and 17, here at Yale, there were 51 requests for molecular profiling for the Oncomine assay. 24 of these were primary pancreas samples, and 19 were metastases. But in all of these 51, almost 30%, the tissue was actually insufficient to perform the assay. So this gets to this point. So we have here, we are really blessed with not only outstanding surgeons, oncologists, but with fantastic interventional radiologists and advanced endoscopists who give us in pathology really glorious samples that we can help the patient with. First of all, so this is a pancreatic core biopsy, and this is sort of a 200x high power view. This is a fantastic amount of tissue. It is very easy on H&E, and one quick glance, we can make a diagnosis of adenocarcinoma. Wonderful. And there is some tissue left in this core, which is about 3 millimeters thick at the most, for assays to be done. But you can imagine if you first send it for Oncomine and then later on want something else for a specific trial, you could easily run out of this tissue. To touch on the primary versus metastasis issue, I'm just going to share a stain from the mesothelin clinical trial in which we look at the stain to see if the patient is eligible. So they have to have staining. This brown, crisp, clear stuff is membranous staining is positive. And it turns out in the literature, and certainly in our hands, in primary tumors, the mesothelin stain is positive in about 70 to 80% of all comers in a resection. So this is great. Patient is eligible for the trial. However, in this particular trial, most of the specimens that I'm receiving to assess and look at this stain, the samples are mostly metastases. And I'm finding that in the metastases, probably only about 25 to 30% of the samples are positive. So here's a metastatic biopsy. It happens to be negative, and that's what we're finding. So clearly it's different than the primary. And so if I happen to get the primary on a patient because their MET hasn't been sampled, but it's been proven radiologically, patient might be enrolled in the trial, whereas if their MET had been sampled, they might not. So these are issues that can come up in a variety with a variety of markers, and at some point they have to be considered. This is a metastasis to the liver of pancreas adenocarcinoma that last week we were asked to do a PD-L1 stain to see if off-label if the patient could be treated with a checkpoint inhibitor. And in using GI criteria for that, this stain, again, the chromogen is always brown, can be very tricky for us to analyze. And so the other sticky wicket here is that there's a propensity for inter-observer variability in the interpretation of the PD-L1 stain when it's not when it's completely negative and not when it's floridly positive, but when it's barely positive. We're meant to count membranous staining in tumor cells, and there's a little bit here. Ignore the cytoplasmic staining, but count the staining in lymphocytes and macrophages. And so you can imagine that can be challenging to come up with something. Finally, this is an MLH1, one of the mismatch repair protein immunohistochemical stains that we are sometimes asked to do. In pancreas, we're certainly doing it all the time in other settings. And the issue here, it was once again, if you're dealing with small tissue fragments, first of all, the incidence of microsatellite instability is really quite low in pancreas compared to other organs. And if you're dealing with a small biopsy, we need 4 slices to do these sets of stains. And so one can easily imagine that if we do those 4, it means we may not be able to do something else on this tissue later on. And finally, this is my last slide. So these are just some considerations as we get into the nitty-gritty of modern therapeutic options. And I think that, so what do patients need from us? I think at Yale, we can say with humility and some pride that the patients receive outstanding patient care from the teams, and they get really accurate tumor staging from the groups that are involved in this as a starting point. And the goal, obviously, is to transform this disease from a death sentence to prolonged survival. So I think we all agree that, if for the tissue part of this, the part of this that is related to making some leaps in therapeutic options that have to do with looking at that patient tissue, we need a forward-thinking, coordinated, and really synergistic approach to the research. And so I think if Yale is to be a thought leader and a change agent in pancreas cancer, and having to do with the tissue, we need a uniform procedure and financial support for a state-of-the-art tissue banking that includes clinical annotations, serum samples, and the whole works, including the routine obtaining of upfront non-clinical samples to be archived for research in all patients. This is the pathology, the Yale Gastrointestinal Liver and Pancreatic Pathology team, and we thank you for your attention.